So I'm going to talk about implementation facilitation, a bundle of strategies. So what is implementation facilitation? Who in this room has heard of that before? Anybody else? Okay, so all new, great. So it's a multifaceted process of enabling and supporting individuals, groups, and organizations in efforts to adopt and incorporate evidence-based practices in routine care. And it's really meant to be very participatory and collaborative in nature. And this just shows from a paper that was just published, the number of citations of articles that have cited it. And so you see it's increasingly used in practice as an evidence-based bundle of strategies. When we have turned to using implementation facilitation, we turn to leaders who've been using this in the VA setting, which is the Veterans Affairs healthcare system, to help promote practice change. And they had developed this to promote behavioral interventions in primary care. And please feel free to interrupt. You guys know I don't like to. Oh, Veterans Affairs. So it's our health system for veterans. So this is now the third version of the manual that has been created, and this is a really friendly, readable guide to how to implement implementation facilitation in. Oh, it doesn't matter. That's okay. Thank you. And so I encourage you, if you're thinking about this, to look at this guide here. And really an overview of implementation facilitation, as we've heard about over the past couple of days, there's a number of frameworks that you can use that are determinant frameworks to help you think about what is the push and pull for bringing forward an evidence-based practice in a particular setting. This group, and actually I also have often used the IPARIS framework, which we've heard about. And that's really thinking about what are the context-specific factors, what is the innovation, the evidence-based practice, right? Again, this is implementation work, right? How do you get an evidence-based practice into a particular setting, and who are the recipients, right? Who are the patients and the providers you're trying to reach to bring that all together? So with thinking about implementation facilitation, you're thinking about all those pieces and the partners and how they interact, and then what are the helping needs or the facilitation needs to then generate successful implementation. Guys, please feel free to interrupt me if something doesn't make sense. And there's been, growing literature in this space around, who's going to be a good external facilitator? What kind of characteristics does that external champion need to have? And here are some suggestions and guidance, right? It's going to be someone who's good at building relationships and creating a supportive environment, right? This is really intended to be collaborative and not a top-down approach. It's recognizing that you really need the input of the people who are going to be on the front line to work with you to help understand what the needs are, what are the barriers, right? And how to move it forward, right? It doesn't work otherwise. So you want someone who's going to be good at that. You want someone who's going to change the system of care and structures and processes that support it. Someone or a team that is helpful at transferring knowledge and skills and creating infrastructure for support for ongoing learning. Someone who's planning and leading change efforts and can assess people, processes, and outcomes, and creating infrastructure for monitoring, right? So we've talked a lot over the past few days around like audit and feedback and how that's really important, is using data to help understand, what the gaps are and feeding that back to inform change. Yeah, that's right. So thinking about creating local implementation teams, right? You can imagine this might take a couple of different structures, right? These are just two examples, right? So where you have external facilitators who are not part of that context where you're working, and either you connect with an internal facilitator, so somebody who maybe is not at that clinic, but oversees those clinics, right? So it's not someone who's embedded there, and that serves as an internal facilitator, right? They're part of the system, but not in that specific clinic, right? And you're going to have a site champion, right? You always need somebody who's on the ground, who's really going to be bringing the energy and driving things, right? You need somebody, otherwise it doesn't happen. right? And it could be a couple of people, but you need at least one site champion. And then you're going to have your implementation team. It's going to be that group of folks who are going to be responsible for helping, just bring the energy, help make sure people are educated around it, maybe are the local source for when questions come up, and helping develop those processes for audit and feedback. In another model, you may not have an internal facilitator, and the external facilitation team is working directly with the site champion and the implementation team. But that implementation team is really going to be the group that's going to move that work forward. So when thinking about implementation facilitation, there's a number of implementation strategies, and we've talked about this over the past few days. It's really a bundle that comes together where you have an external facilitator who's really the expert in the evidence-based practice, right? Who knows a lot and has been doing it and is bringing that to this new context. You have a local champion that's going to be that site stakeholder who promotes change. You're going to do provider education and academic detailing. So again, we need to make sure that people know what are the unbiased data, right? And who's heard of academic detailing before? Academic detailing. Do you see this here? So we think about it as something that's different than the pharmaceutical. How often do pharmaceutical representatives interact with the healthcare system here? Right. What do you guys think about the information that they're sharing with you? Not valid. Oh, what was the first thing you said? Right. Right. And you think it's biased or unbiased? Right. They're trying to drive you to prescribe what they're selling, right? And it's really biased. So I think about academic detailing as kind of a similar model, but it's unbiased education, right? These are the data. This is why you should prescribe that hydrochlorothiazide or whatever, right? That cheap drug because it works, right? And these are the data, these are the risks and benefits. But we were talking about brief interventions yesterday in SBIRT. I think of academic detailing as an SBIRT for providers. So it's provision of unbiased information to providers with a brief intervention. So it's like, what are the barriers and facilitators to adopting this evidence-based practice change? What's getting in the way? What would make you more ready, right? And then you can tailor it so you're reaching out to the providers who are lower adopters of that evidence-based practice and helping move the needle in the area that you're really interested in. And then you set a plan for follow-up, right? And so it's very much like a brief intervention. And it's a lot of fun and makes so much sense. Stakeholder, yeah, please. I have on, I think the next slide, I'll show you a great center for resources. Stakeholder engagement is another key part of implementation facilitation. So getting to align the goals that you have with those of the organization, right? And making sure that they're on the same page, right? It doesn't matter if you have this, let's get to 100% prescribing, but if they're at 0, you have to maybe set something in the middle that feels achievable with the time that you have, and then you kind of move the needle and help them move in that process. It's really important, as we've talked about, the context matters a lot. So tailoring the program to the site's needs. So it's really helpful to understand what those site needs are upfront. Performance monitoring and feedback. Audit and feedback is a key strategy for helping with movement of evidence-based practices. And so working with sites to measure this. So I'll tell you a little bit more about one of our studies, but maybe in an HIV clinic, they're checking for lipid screening or syphilis screening or tuberculosis screening, but they're not thinking about tobacco use. So how do you help them think about processes they have in place already to then prioritize metrics for that target evidence-based practice that hasn't been adopted yet? Does that make sense? Formative evaluation. So that is a process where we use these mixed methods often to understand, and over time, to understand barriers and facilitators to what is going on and getting in the way, and can facilitate adoption of that evidence-based practice. And I'll share with you briefly 2 studies that we did where, thinking about who that stakeholder group is really important, right? And who you're going to speak to. Establishing a learning collaborative. So as you start to work with your local stakeholders, you want to provide an opportunity, and Rick talked about this. You want to create opportunities for sites to learn from each other, right? And build those relationships so that you're not doing it in isolation, and creating a forum for that. And then program marketing. So what I have here is how we did in our study is like trying to increase attention to availability of on-site addiction treatment. And so maybe you have to create some patient pamphlets for the waiting rooms, or you want to have pens lying around, right? Just to raise awareness the way we do for, the way pharma does, right? We got to do it better. Okay. Implementation facilitation is strongly evidence-based. There was one review in 2012 that demonstrated that it's associated with a 3-fold increase in adoption of evidence-based guidelines. And there's been a number of reviews since that time. So it's a very helpful strategy. Questions about these key components?
Slide that had all of the processes around the dose, the actors, and all of those other sorts of things, those 9 specifications, you'll want to specifically say for each of the strategies, including the implementation, facilitation, to really lay all that out as much as you possibly can, and any other sort of facilitations or any other strategies that you're going to use with that. Dose, all those things.
No problem. So just to give you some resources, so if you're interested in learning more about academic detailing, this is a great resource here. This is out of now Boston University. It had been at, the team had been at Harvard, at Mass General, but now is at Boston University, led by Mike Fisher. It's the National Resource Center for Academic Detailing, called NARCAD. They have a number of trainings that you can participate in. They have a number of toolkits. And again, it's really this idea of how do you bring evidence-based interventions, educate providers on a 101 basis, or maybe in a small group basis, in person or virtually, to understand the evidence-based practice that they haven't been implementing and the why, and help them think about barriers and facilitators to doing that. They have a number of toolkits that I just wanted to make you aware of in case it's of interest to you. And so you can see these here. So I had shared with you some of the work we've done in the context of evaluating implementation facilitation in a hybrid design, using a type 3 design where we're focused on implementation outcomes to promote adoption of addiction treatments for alcohol, tobacco, and opioid use disorder in 4 HIV clinics in the US. So we took that manual that I showed you, I think on the second slide, and tailored it for our study. And so it's a manualized intervention, and we detailed the things we did upfront to do the work with those sites. So site visits, focus groups with the clinicians and staff and patients to understand what the needs were, working to foster local champions at those sites to work with us, working with them to try to promote practices for audit and feedback. And so again, this is like a manualized strategy that we try to make sure that it's out there for people then to tailor it for what they want, use what they like and what they don't like, and tailor it for their evidence-based strategy that they're trying to adopt. So for, in our context, these were the things that we did. It was over, with the step wedge design, we worked sequentially with each site pretty intensively. And then as each site rolled, finished that 6-month period of the facilitation phase, we invited them to participate in learning collaboratives. And so they were sequentially supported in the movement and their evidence-based practices. I shared with you some of the results from that study, so I'm not going to belabor that here with the interest of time, but wanted to share with you, we learned from those experiences and then use that strategy in the context of promoting emergency department initiated buprenorphine. So we know that when patients are coming into the emergency department, there are likely that group of patients that are not engaged in care anywhere else. We know that buprenorphine as a medication for opioid use disorder is really helpful for getting patients into care. If it gets started in the emergency department, so you start buprenorphine in the emergency department, give them a referral, and that doubles their likelihood of being engaged in treatment. And so that work had been done prior to this study that showed there was a strong evidence base for initiating buprenorphine in that context. And so then we were working with 4 emergency departments across the US to help promote adoption of that practice. And so again, we used a similar strategy, tailored that manual that I showed you. We did, I think, like Rick, I think you said yesterday, I will never do like all these focus groups or interviews. We did like 70 focus groups across the 4 sites. I mean, it was just, it was 3-4 day site visits to each of the emergency departments. Several of us, including emergency medicine physicians, addiction medicine physicians, and I think it was 4 or 5 of us that went to each of these sites and spent 3 and 4 days really getting to know the sites, helping to bridge partnerships with the emergency department and the local communities, right? Because they didn't actually know their local treatment providers. So it was really trying to bridge those silos and getting to know. We did focus groups with the emergency medicine physicians, the residents, the pharmacists, the social workers, the case managers, and then a number of community sites where these patients could be referred because those processes weren't in place yet. We worked with those sites and went back and did, a visit, several months later, and then a 3rd visit. So we did that sequential formative evaluation where it was, in the beginning, I forget the words that Stetler uses for the formative the summative phase. And in any case, it was a series of site visits and working with the teams and then developing these learning collaboratives. We did rapid assessment where we fed back to the sites a synthesis of the information we had learned so then they could start to build their own processes, develop audit and feedback processes to work with their providers. And working with them to also share successes, right? It's so important that sites start to hear about the successes and not just, especially in the ED setting where you don't necessarily see the successes, right? It's a success as those patients who aren't coming back because they're doing well and engaged in care, right? And so we have to build those reinforcing pathways. And so we worked with some of the communities to, they were writing letters to the emergency department to share successes. And so what you can see here is, this was from the outcomes paper published in JAMA Network Open, looking at the number of ED visits with buprenorphine administration during the baseline phase. And then we saw quite a significant uptake and provision of buprenorphine in the facilitation phase. This is just broken down by site. And then we saw an increase in the unique number of ED clinicians who are administering buprenorphine as well. And then here is just looking at the implementation outcome. Again, this is looking at patients receiving ED-initiated buprenorphine. So this is on the patient level and the effectiveness outcome. And so we saw a significant increase in the number of patients. It was 14%. So of course, we want to see that even higher, but we're pleased to see we saw improvements there. And then we found that those who received buprenorphine were significantly more likely to be engaged in care for the effectiveness outcome. And so, again, a big bundle, lots of work to be done, continuing to move the needle. And so this is an evolving literature around how to bring this implementation facilitation strategy, how to improve it, what are different things that to be thinking about. These are just some papers just to show the evolving literature in this space. So what are the characteristics of a facilitator? How are you going to sustain that facilitator, right? And keep them like Lynn and positive, right? And engaging. How can you translate this to virtual spaces, right? If you're not necessarily able to go do these site visits and be on the ground. And there's a number of best practices that have been identified. And then even a tool for this reflective writing to support continuous learning for facilitators to think about what's showing up for them So there's just a lot of interest in this space, and just to share some of those references with you. Lastly, I think there's varying levels of love for logic models in the room. But this is a paper that's looking to understand what is the mechanism by which implementation facilitation is helping to change practice. And this is a busy slide. I'm not going to walk through it too much, but just to highlight that, again, it's thinking about the characteristics of the recipients, it's thinking about the context and the different phases of the implementation, the pre-implementation, the implementation phase, and then the sustainment phase to help move the needle in those implementation and service outcomes and patient outcomes. You probably recognize this from the Proctor model that we talked about, right? Does that look familiar to everybody now? So I'm going to stop there and happy to take questions, comments. Looking at some of these reviews overall, it's a strategy that helps move the needle, right? But I'm sure there's some studies, I don't know the references off the top of my head of where it doesn't work. It's a really time intensive, again, collaborative process. And so I think that's one of the things to balance is like, do you have the resources to do that? And I think that can be something to really think about, is how to make sure that it's a reproducible strategy.
I'm just wondering, either between the various different settings, have you had to modify or adapt your implementation facilitation in terms of how you did it? Or did you find that the coaching part of that, there was a mismatch where you had to change the coach who was doing that because they weren't meeting the needs of that specific site? So what I call the coaching mismatch.
I don't think there wasn't a lot of changes in the coach, I guess, in terms of thinking about the variation in the way we worked with sites. I think part of it was figuring out like what was the local context and the resources for who could be the champion and how those processes worked. In terms of like our external facilitation team, that didn't change during the course of the study. Does that answer your question?
They've talked about the mismatch, and part of it usually has to do with style. And, most of the implementation facilitation sort of strategies are people who are using more sort of motivational interviewing types of styles with engagement. But there have been times when people have been hired who were a bit more autocratic, which becomes more like an audit and feedback or an expert, guidance. And so they've had to sort of shift from that. I'm just wondering, did you ever have to deal with it, and when did you deal with it, and how?
I mean, for the different studies, there was some overlap in the people who were involved, and probably pretty different styles. Yeah, absolutely. Okay, Rick, I think you're up, or Mona. Yeah.